about the treatment of OUD. And obviously, since we're here talking about medicines, our focus will be MOUD, but remember that there's many modalities, and we think of MOUD as part of an integrated holistic whole, but our focus today is on the medications. We can go astray into other modalities in addition because they're so important, but at least let's start off with our focus on the medications. And it can both be a very simple, straightforward thing. Get people on medicines, keep people on medicines, you will save lives, it's the right thing to do, it's the standard of care, shut up. On the other hand, it's complicated, and it's not so easy, and there are barriers, and patients aren't always buying what we're selling, and these are difficult disorders in a complicated, chaotic patient population, especially in criminal justice involved folks. I don't have to tell you that, and so wanted to just talk about general principles, your experiences, your frustrations, barriers and overcoming barriers, thinking about issues at a 30,000-foot level if you want, or into as much nitty-gritty granular detail into the measuring of milligrams if you wanted to get that much into the weeds. So I'll just start by highlighting these points that I wrote up here, just kind of thinking in a broad 30,000-foot way that you want to think about medicines as having at least treating people with medicines and improving impact and improving effectiveness of treatment with medications for OUD as having these kind of early, middle, and late phases, and whether the timing actually is middle or late or early, but thinking about them in this way, getting people on the medicines, and there's lots of barriers in doing that and difficulties in doing that. Some of them system issues, some of them policy issues and access issues, and some of them issues of initiation in the era of fentanyl and pharmacological problems with that. But then there's how to get people on the right medicines and choosing which medicine and how to improve dose and how to improve adherence and keeping them going and managing the expected cycle of remission and relapse, right? Because we don't have a cure, and these medicines, as good as they are not curative, and so we expect 3 steps forward and 2 steps back. That's just the course of this illness. And then going for the long haul, improving retention, right? And we're keeping people engaged, because it's one thing for these patients to get into treatment, it's one thing for these patients to get well initially, it's another thing entirely for them to stay well and to stay in treatment. So I thought that's one way of organizing the conversation, and I could certainly, as I say, lecture till midnight about all 3 of these things, but rather than my doing that, are there things that you guys in particular wanted to talk about, hear about, ask about? Burning questions?
I have weed one questions.
Yeah.
So, the lady from Rhode Island said that the reason the patient was nodding off, it was because they weren't good, because we had a patient that was taking, she's nodding off in the day room, which is scary in our world because you want you to be cognizant so somebody won't knock you upside the head. But so she's nodding off, and she was on all kinds of mental health medications, and I think she has some other underlying. And the lady from Rhode Island said in their experiences is that they needed to increase the amount of medication that they were receiving.
So this is a real and important consideration in the managing medicines of all kinds, namely side effects. So medicines have side effects, and I wish that weren't true. I wish that I could cure what ails you, not just an SUD, but you name the subspecialty of medicine, and guarantee that the treatments are perfect and worry-free. But it ain't so, and even Tylenol has side effects, and if you, I hope none of you have had the burden or experience of having had treatment for cancer, but maybe you have loved ones who have, or you know people who have. Sometimes it's a race between what's going to kill you first, the cancer or the horrible treatment. I mean, the life-saving treatments, but the treatments that are fraught with side effects that we doctors torture patients with. And it's an unfortunate trade-off in our tool chest. Well, these medicines are no different. They're great medicines, they are life-saving medicines, they are the standard of care. I encourage people to use them without hesitation, but they are not perfect. And they have side effects. And one of the side effects that we get concerned about, especially with methadone, but also to a lesser extent with buprenorphine, not so much with naltrexone. And when I say that naltrexone and others don't have this particular side effect, I'll give you 7 others that they do have, and it's a trade-off, and that's what we do when we pick medicines. I hate to see it, but it's a matter of pick your poison. It's just which poison is less worsener and more betterer. And so let's talk about sedation. For sure, methadone can cause sedation. And that tends...
She's on Subutex.
Okay. True of buprenorphine. For sure, buprenorphine can cause sedation. Tends to be more of a problem earlier in treatment. Most patients, for both methadone and buprenorphine, will accommodate to that over time. And so accommodation or tolerance, that is the side effect of sedation, getting used to it, body accommodates, body gets used to it, and that fades away. But not everybody. There is no side effect that everybody gets, and there is no side effect that 0 people get. And even when we say, one of the things you should never trust when a doctor says is, this won't hurt a bit. Never believe that, right? So there are gonna be troubles for some people. And though, as I say, most people, the sedation will get better over time, there are some people for whom it's a deal breaker. And if the dose that I need to reduce my drive, reinforcement, and hunger for heroin fentanyl is so much methadone or so much buprenorphine based on my individual body's biology that it puts me in a coma, I don't know if that's worth the trade-off.
So there's no one-size-fits-all?
There is no one-size-fits-all. Other factors to consider are what other medicines are you on?
Right.
And you mentioned that this person was on other medicines, some of which may be sedating as well. And ingredients in the stew can add up. And sometimes it's arithmetic adding up. This sleepy medicine plus this sleepy medicine plus this sleepy medicine. And sometimes it's more than arithmetic, right? And there's a synergy in which it's more than the sum of its parts. And this one plus this one plus this one is 10 times as strong side effect-wise as any of them individually. So instead of a 3-time multiplier, it's a 10-time multiplier. And sometimes we can predict this, and sometimes. So good practice is thoughtful, is not formulaic, is not just reading the recipe. It's improvising and following patients and having them teach you back from their personal experience about what's working, what's not, and being open to that, and being open to have a hypothesis and change your hypothesis based on the data. And no, we don't want our patients to be zombies and in comas. I would say that it's always worth, for this particular side effect, sedation, always worth hanging in there and seeing what happens, because as I say, most people will accommodate, but not everybody. And so maybe it's a question of adjusting the dose. Maybe it's, as I say, a tincture of time and waiting. Maybe it's readjusting some of the other medicines. Maybe it's adjusting the timing of the taking of the medicine. Because one of the things that we know is that the benefit of a medicine in its course of action over the course of 24 hours may not have exactly the same time course as the side effects. So for example, there's some medicines that give you a tummy ache if you take it on an empty stomach. There's some medicines that give you a tummy ache if you take it if you've eaten, and you need to take it on an empty stomach, right? And there's some medicines that make you sleepy, so maybe you should take them at night, because that's when you're asleep and it's not a big problem, and on and on and on. So it's kind of learning those kinds of tricks. Now, one of the places where we see this problem of sedation is in residential substance use disorder treatment. I don't know if that's the context you're talking about, but this happens all the time, in which a patient who is having trouble, say is off their bute or off their methadone, comes into residential treatment because they need the high intensity of stabilization temporarily to get back into being able to take advantage of outpatient treatment. But they've been off their medicine, and so they go from 0 to 110 of methadone, or 0 to 30 milligrams of buprenorphine, because that's what they said they were on. Right. Oh, did I neglect to tell you I haven't taken it for a month? Right. And now they're sleeping through group, and they're triggering the other patients, and they're nodding, and they're intoxicated. That does two things. First of all, it's a bad side effect profile for the patient. But the second thing it does is it gives the medicine a bad name, because everybody looks at this patient and says, see, that's what methadone does. It makes them high. That's what buprenorphine does. It makes them high. Well, this week, yes, under these circumstances, with this side effect profile, with this time course, but that's not a condemnation of the medicine writ large. That's just this unfortunate intersection of timing and biology.
And it was a context like that, similar, it just happened to be in jail.
Okay, same idea. Yeah.
Yeah. So that leads me to the question on what time of day is best. Now, it's
for dosing buprenorphine.
We're dosing, because in a jail, it's when it fits in between head count and
sure.
People get, and see, and another challenge is it's so hard to get nursing staff. They all want to work Monday through Friday, and they want to work 7 to 3. And when I talked to the lady from Rhode Island, because we've tried it at different points of the day, and it's easier for the staff to do it in the morning, but she kind of suggested that maybe it was better to do it in the afternoon or evenings, because she said sometimes if you get it in the morning too soon, then it does really start to wear off, and they feel that. And then the other thing is sometimes if they get it too late at night, then it's like they're ramped up.
Yeah, the majority of people don't get that ramped up, but I do know that some people do. Okay. And interestingly enough, when we first started working with buprenorphine, we were convinced that once a day dosing was probably going to be best for everybody. And that's what the mouse studies taught us, and that's what the human lab studies taught us. But it turns out that people in the real world don't read the textbook. And so biology is a funny place, and most patients turn out to prefer at least twice a day dosing because they do find that they feel it wear off by the end of the day.
So it really is true, it does wear down.
It does for some people.
Okay.
And on average, though, more people than not. So if you take 100 people on successful buprenorphine treatment, 70 or 80 of them will say, yeah, I dose it twice a day. And even though my doctor tells me to take it all in the morning, I take half in the morning and half in the afternoon or in the evening or whatever. And interestingly, the blood levels are still pretty high by the end of the day, but they're not quite as high, and people feel it wears off. And they experience that in a number of ways. They might experience it because they have increased craving. They might experience it that they don't have the sensation of, I feel it, which is a peculiar thing that happens to our patients with SUDs, right? Because you don't feel your lisinopril for your blood pressure in the morning. You don't complain to your doctor, Doc, I take my lisinopril, but I don't feel anything. That's good. Thank goodness you don't have side effects. You're one of the lucky ones. But our patients are reinforced to want to feel something, and it's hard to let that habit go. So that might be an issue. And then the third issue is they might start to have mild withdrawal. So by the end of the day, I'm a little anxious, I get a little hot and cold, I get a little aching in my bowels or in my bones, I have insomnia, whatever it is. And of course, those symptoms, however mild, are potential relapse triggers because they're thinking about what that reminds them of. So you could criticize them for being drug seeking. On the other hand, it's real, and it's probably helpful to follow that biological cue so that they don't have that discomfort, which is so reminiscent of the symptoms of the addiction, so that they're feeling smooth throughout the day, and that's okay.
I have one more question.
I have had patients who say twice dosing is not enough, or 3 times dosing is not. I had one patient who would nibble on the Suboxone all day long like a little mousey. That's excessive.
And it worked for him.
I don't know if it worked or it didn't work, but I'm just saying, as I say, biology is a funny place, but in general, 2 to 3 times a day dosing gets most of the people. And if a person says that they need to do more than that, At home, I'm not going to fight. Now, that's not practical in an institutional setting where you have to do direct administration. And so it's a balance. What's optimal for the average patient, and who is the average patient, right? So everybody's a little different. You can't customize everything differently for 1,000 million people, right? You got to have a standard, and it's got to do with staffing and practical issues and logistics and all that. So it's a compromise. And so here's what you would do if you had all the money in the world and all the staffing in the world, as I'm sure you do, versus working on it, right? That's a next quarter's requisition, right? And what you have to do to make ends meet. And here's the nursing shift, and once a day dosing is all we can manage, or 2 times a day dosing is all we can manage. Okay, it's better than nothing, and it's always a compromise. The classic example of that is in methadone treatment. There is a subset of patients who, for most people, methadone is a long-acting medicine, and once a day dosing, even once every other day, or even every 3 days dosing is good for a lot of people. There are some people who are fast metabolizers and really would benefit, and this is especially true of pregnant women, would benefit from twice a day dosing. But it just doesn't make sense for the economics of most OTP methadone delivery because they're open from 6 to 12, and if they had to pay nurses to be open from 12 to 7 at night to be able to accommodate everybody's needs, that would make methadone treatment unaffordable, at least as commonly practiced. So it's a compromise.
And then my last question is because, as part of our job as administrators and such, you have budgets, so you take it. So I asked the pharmacy for a quote, and they came back and they said it was about $29 and some cents, and that's what I used. And so yesterday.
For the medicine?
For the medicine. However.
For one pill?
No, for a month.
Okay, fine.
But then when you look at it, like to look at our invoice, it's like they've got, like the same guy, he would get buprenorphine, like 2 milligrams, and got that, they ordered that on like April 14th, and then, I told you the weeds, and then buprenorphine, 8 milligrams on April 11th. So, why is there such a disparity, like between a 2 milligram and an 8 milligram? Is it because they combine? I mean, they get the methadone or the buprenorphine once a day. Why is there such a difference? Because, the big difference between $29 and $62, because of the cost of the medications.
So slow down a second and make sure I understand. You're saying 2 milligrams
Right.
for a total of 2 milligrams per day.
Well, I'm not sure. It just says, we've got 30 buprenorphine.
32s
32
is
milligram
of
buprenorphine.
$29.
And then,
Thir-
that was $21.73.
Yeah, okay.
And then they had like
38.
45, then they got 45 buprenorphine, 8 milligrams, and that was like $40.37. And I get that the strength would make a difference.
And it's
So
not linear.
like
It's not
one-
linear. You notice it didn't go up times 4.
No, it didn't.
Yeah.
No. But, so it just depends on what the patient needs. So like this person must need like 10 milligrams at a time.
I see. So you're asking a bunch of questions. One, the more important question is how do you figure out what the right dose is for a person? How do you individualize that? And what's the variation?
For my purposes, this is the doctor's job to find out, but I need to be able to pay for it.
Absolutely, absolutely. So another important question. So in your vignette and scenario is the question of how do you decide who needs what and what's the variation?
But that was the same guy. They got like.
Yeah, that's right. And how does that evolve over time? And what forecasts can you make on average? And then how does that get priced? So the pricing question is mysterious to all of us. If you're asking me the question, what is it that big pharma does to make decisions?
But it's not a one size fits all.
It's not, unfortunately. Now, it's less variability, say, than cancer treatment, but there is some variability. So on average, classically, pre-fentanyl, 16 milligrams looked like a pretty good dose with a range of 8 to 20 for most people. Now notice, even then there was a range. Now we're going to upshift that dose range in the current era of fentanyl, and we can talk a lot about that, but the high potency fentanyl requires generally higher doses of all three of these medicines, naltrexone, buprenorphine, and methadone. So now let's talk about a range of 20 to 32 even, although you won't see most of your physicians prescribing 32, but stay tuned, and I guarantee you the practice will shift that way as we learn more. But currently, practice is probably still in the 16 to 24, but heading north because of the potency of fentanyl. And sometimes doctors will get you there quick, and sometimes doctors will get you there slow. Part of the difficulty in an institutional setting like a jail or residential treatment or elsewhere where people are mostly abstinent by confinement is that you're flying a little blind in terms of customizing the dose titration for the patient, because the way we would do it for an outpatient is we'd see how it's going with their daily temptation, and they're in a drug-infested neighborhood, and they're constantly bombarded with the temptation to try a little, to skip their dose of buprenorphine and have a little fentanyl instead. And that dance helps us zero in on what's the right dose for me to be able to prevent further lapse and testing of the blockade and that kind of thing. And so I might be able to do that quickly, or I might be able to do it only after weeks and months of getting to know a person and what their trajectory of stability, abstinence, lapse, relapse is like. In a jail or other confined area, you don't have that feedback, so you're heading for averages based on side effects for sure. You don't want to over-sedate people, give them side effects, and you want to hit what you think is a reasonable dose, but you don't know what it's going to be like when they get out, but that's okay. So I don't know what happened in this case, but getting most people to around 16 in a setting of confinement, a little more, a little less, is probably what you should expect. And then it comes in different formulations. It comes in a tablet,
Yeah, we use a tablet.
comes in a film. Film is obviously more of a problem in terms of contraband and security. I don't know the pricing, but they are all in generics now, and so you can negotiate. No,
Yeah,
you're not a
I'm
big enough
good.
buyer
I
to
was just-
negotiate.
I was
Yeah,
just
but
really-
you get them from a wholesaler in stock, and like you do all your medicines, like you do your lisinopril. And
I was just surprised that, I got a price quote for one thing, and then when you look at the actual bill, and it's such a price disparity,
Mhm.
I just figured you would
Yeah.
order buprenorphine,
Right.
I
Now,
would
the
get it like
reason
one,
we
and
might-
not have Mary Ann Thompson and have like multiple.
The reason
buprenorphine.
you see twos, because you notice I said 16 or 20 or 24. What does that have to do with twos? Those could be multiples of 8, right? So what's the twos for? Well, the reason you might have twos early on is because individuals with OUD in confinement may have lost their tolerance because they haven't been on the street this week, this month. They might not have been using recently. That doesn't mean they don't need treatment. That doesn't mean they've got a whole bunch of recovery skills and still don't need to be on buprenorphine or other MOUD. It just means they're non-tolerant, and you can't go right quick to a full dose. You got to go slow to minimize side effects. So instead of starting someone as you might right off the street used yesterday at 8 milligrams twice a day, 16, or 8 milligrams 3 times a day, 24, you might give them 2 milligrams a day for a few days.
Okay.
And then 3 milligrams a day, or then 4 milligrams a day.
Okay.
And maybe you can speed that up a bit, but the idea is you've got to rebuild their tolerance to get them to an average effective dose. So again, it makes your inventory forecasts a little wonky.
Yeah, I just have
Yeah.
to take and regroup, because I was thinking one thing, but the reality was something different. And I think that's it, as we go through this process, everybody's figuring this all out.
Yeah.
But that was my list.
Comes in, again, lots of weeds. It comes in 2s, in 4s, in 8s, and in 12s. And you can probably get away with just having 2s and 8s and make most multiples out of that without having to buy 12s and 4s.
Right, and
yeah.
it's, like I said, I don't, whatever's ordered is what is needed, I'm good, I just want to be able to pay for it.
Yeah. Now, having said that, it's too bad that the injectables are so expensive.
Oh, yeah, they're just pricey.
They're very pricey. And we are not at a point yet where we have those available as generics. That's years away. Obviously, the advantage to the injectables are reduction in security contraband issues,
Staffing, nursing.
reduction in staffing and administration, and improvements in adherence post-release, because adherence to daily medicines is a big problem for patients. I mean, I can't even take a full 7-day course of antibiotics when I'm sick, and that's just, 7 days, and it's curative. And after 3 days, I feel better. Who needs it, right? It is the rule, not the exception, with all chronic illnesses, whether it's diabetes or hypertension, et cetera, that people have trouble with adherence to daily pill taking, and it's magnified times X in this disorder because there's lots of temptation for, well, maybe today is a recovery day, but I heard my friend has some really good stuff and I'll take my buprenorphine tomorrow. And this fight between angel on one shoulder and devil on the other shoulder is hard for people in early recovery. But a once-a-month injection takes some of that ambivalence out of it and really helps with adherence. But very pricey, right? So wholesale price for either extended release naltrexone or extended release buprenorphine is upwards of $1,000 a pop. And that's hard to sustain.
It is.
Yeah.
Versati is like 1,800 when I priced.
So not just upwards, but upwards.
Right, that's more than Vivitrol is 1,000, but.
Now, we're lucky to be in Maryland, where both of those medicines are very liberally covered under the Medicaid program. But that doesn't help you
No, it does not.
behind the walls. Yes, I understand that. So please write your congressman about the Medicaid problem for incarcerated people.
That's a big, big issue.
It is a big issue.
That's a rabbit.
Maybe beyond the scope of today's conversation, but it is a big issue.
So yes, Dr. Fishman, good to see you here.
Yes,
we
great
have
to see
long
you.
relationship together with you
Exactly.
in Maryland Treatment Center in Montgomery County. So first of all, good to see you.
Good to see you, and thank you for helping the citizens of Montgomery County. It's been a great legacy.
Absolutely. The topic I would like you to address from a medical perspective, obviously this morning, this whole Pandora's box of buprenorphine diversion, that topic, obviously on the correction side of the fence, the holy grail is custody and security drives all, and it has to be. It's a jail. We all get that. And so, in just thinking about, I guess, some of the issues that have come up for us in our Montgomery County project since we implemented January of 2020, obviously over and over again, you will have inmates who clearly do divert a 71 form or whatever is written up, and they are found guilty of diverting, and so they have to be held accountable, and they have limited options of what that accountability might entail. In recent times for us, that's usually come down to either going on Sublocade or a mandatory detox, one of the two. So part of my question would be, medically speaking, what is your understanding of what the different options might be for somebody who clearly has diverted and has been found guilty in a Maryland jail? Now, that's one of the questions.
Okay.
And then the second part.
Oh, wait, it's going to get tougher now. Oh, my God.
No, this is actually the easy part. Because this is fairly new, I'm just wondering about your knowledge of anything that's written in any journal, whether it's medical or otherwise, that addresses the different options of what to do when somebody, again, has diverted. Again, they have limited options, but when we were talking about uniformity of policies, and I think on this diversion issue, if Maryland could arrive at some uniformity on it, it might be a great coup or victory. That's just my thinking at the moment. But I just wanted to hear you address it in any way that you could,
Yeah.
because like I said, I know it's occasionally where we butt heads a bit, between the treatment end of business and the corrections end, even though we recognize, because we've had presence in the jail in Montgomery County for years.
For
and
forever,
we know custody and security drives the ball game, or the bus,
Yeah.
or whatever we want to call it. So any way you can
Yeah.
address that would be great.
No, let me give it a try. I will start with the caveat that I don't know of any really good evidence on this, or good studies.
Okay.
And so I will riff on it some from kind of a sense of good clinical practice and consensus, but take it with a grain of salt that we need more experience in testing some of these solutions. And your notion of trying to get uniformity, it may be premature to say this is the Holy Grail, but it's not premature to say, here's a hypothesis, let's try it and let's check it out. And we could band together and try A, and if A is no good, go to B, and do that without everybody having to reinvent the wheel. Because, you know, there's a lot of counties and a lot of institutional wardens. Now, each of them will want to do the thing their own way to some extent, but if we could collaborate on that, the lessons learned would, I think, come easier. So what do? The first thing is, you're exactly right, that our ability in clinical settings to allow a lot more strikes and a lot more leeway to let people have 3 steps forward, 2 steps back, or 1 step forward and 3 steps back, knowing that it's a marathon, not a sprint. We have much more tolerance, rightfully so. We are able to tolerate that better, much better than you can when, as you say, security and control is paramount. We've got issues of safety and issues of spread to other vulnerable people. And if you've got contraband in one person, you've got contraband in many people, and some of them you can make the argument, well, they're only doing this because they have a need, but that's not everybody. There's plenty of people who are doing it for all sorts of nefarious reasons that end up victimizing people, and you have a culture of illegal trading, and then that turns into violence and sexual victimization and the whole thing. So it is a thing that needs to be addressed, and the question is, what's the compromise, what's the balance? If long-acting injectable buprenorphine is an option, big problem with cost, but
Yeah, but we have friends.
there we go.
We're short-term.
And my
It's been a good one.
and my kids say to me, "Why can't you get some friends, Dad?" But anyway, so you have some. That's good. But if that's an option, that's a really good one. And I use that option in outpatient clinical practice all the time. That is, listen, you've had this really good response to buprenorphine. You say it helps you. I see that it helps you. It's good for what ails you. But you don't take it right. You take it on Tuesday, you don't take it on Wednesday. You sell half of it. You give it to your cousin, and I don't know who your cousin, whatever. So why don't we just give you the shot, and it'll be better. And if I can make that deal, and it's great that I live in Maryland and Medicaid will sponsor that, that's a no-brainer. Oh, Doc, I don't do needles. What do you mean you don't do needles? How'd you get here? Okay, that's another conversation, but okay. So that is my number one go-to. Same medicine, delivery method that deals with diversion, that deals with adherence, that deals with smoothness of dosing. Back to your issue of what happens to the end of the day when they start to feel icky. That doesn't happen with the long-acting injectable. And patients say, wow, Doc, that's a miracle. I don't have to wake up in the morning and feel like, wow, if I can't find that bottle, I'm going to be sick today. Or don't have to worry about, well, if I'm sick and I can't renew my prescription, or if I'm out of town, or you're out of town. I mean, Doc, I love you, but gosh, being tethered to you every month like this is a burden. I get that. So the shot is helpful. Absent that, the question is, how else can we improve monitoring and supervision? And I've got to assume that they're already putting a lot of effort and a lot of resources into the monitoring, and they're watching people, and they're doing mouth sweeps, and they're crushing it, and they're drinking water.
Have to eat a cracker afterwards.
Eat 2 crackers, they're small. That's right. That's right. And so they've maximized that. Are there the next steps? Like, gosh, here you are doing this naughty thing, and I know you want this medicine and you probably need this medicine, but when you do this naughty thing, here are the consequences. And can those consequences, easy for me to say, I'm not having to administer this or pay guards and nurses, but can those consequences be a monitoring system that is short of medication discontinuation? So this is the eat a cracker, drink a glass of water, sit there for 15 minutes, and then this is the naughty protocol. Like, you're gonna have to sit in the nurses, no, that's too burdensome on the nurses, but you're gonna have to sit in this room for 4 hours. I make that up, right? And you're gonna not just drink a glass of water, but you're gonna have to drink 6 glasses of water and 6 crackers, or I don't know what it is. And we're not gonna make this the routine protocol. We're not gonna do it for everybody. You're not gonna have to do it forever, but you're gonna have to do it till you can prove to us that you can handle this medicine and stop being naughty. Again, burdensome, staffing, I don't know if it would work, but is there a graduated sanction where the sanction is not so much about its punitive quality, but it's about its practical implementation to address the problem of diversion? I can do these 7 things that you're gonna hate, but they're gonna keep you from diverting. Stop diverting, and we'll give you a second chance. How many chances do people get? I don't know the answer to that. That's one approach, but it's resource intensive. Another approach is to address, are there other causes? So is it that they are wanting to get high on the medicine so that they're off injecting it? Is it economic, that they're selling it or swapping it for cigarettes or sexual favors or whatever? Is it that they are underdosed, for example, and they're swapping it for full potency opiates like heroin? But instead of one size fits all, can we figure out why they're being naughty? Now, maybe you can, maybe you can't. And at the end of the day, we care less about why you're naughty than you got to stop being naughty. And so I'm not sure that that's practical. Another possibility is to switch people to naltrexone, but many of them will decline. And you can't make them take it. You can say, well, you're unable to handle A, so we've got B and C, and it could be Sublocade if you can afford it, and Vivitrol if you can afford it, or methadone as another option. And they can say, okay, I'll do that because I need something, or they could say, stick it in your ear, I don't want it. Okay, and then you're back to undertreating. I would wonder whether you've seen, you or others, the rates of diversion go down as routine buprenorphine treatment has been implemented.
We still have them divert, you know, I just don't understand why I can get my whole dose, why I would give you my half of mine. I would want my all of mine.
Yeah, I bet that's some of it, right? That I'm asking for this much and I only think I need half of that, and I can make money off the other half.
When you can get your own and then they want to divert it, you know.
Well, the people that they're diverting it to may not be able to make a credible case for OUD. They may just want to have the experience of taking buprenorphine, which is a reinforcing medicine. You know.
It takes a while to make jailhouse alcohol.
That's right. That's right. And mixing it with buprenorphine makes it even better.
Yeah. It just amazes me.
And especially if you take it intermittently, right? So then lower doses can still get you high, and you don't develop tolerance, and it's reinforcing.
And for my purposes, I just don't see the overdose.
Well, now I have good news for you there. I have good news for you there. It's very, very hard to overdose on buprenorphine unless you mix it with benzos or high-dose alcohol. Now, you do have alcohol in the jails, as we just said.
Not supposed to, but.
Oh, I thought it was commissary. Oh, I'm reading the wrong menu.
It would probably be pretty lucrative, like.
I'm reading the wrong menu.
We have to add some have-nots, you know.
Yeah,
so.
exactly. I'd like a 68 red, please. Anyway, grown on the shady side of the slope. But anyway, so buprenorphine is very safe in that way. Now, not that there isn't Xanax floating around the jail too. So it's not like it's zero
There's
use.
still, there were other things as well. It's not just, it's not.
That's
just
right. That's right. That's right.
that.
That's
I
right.
wondered if they were diverting, because we have a lot of them complaining of the withdrawal, because they're only getting dosed once a day at like 10 a.m. And so it's wearing off by nighttime. So I was wondering if some of them, the cheating of their medicine was to have some for nighttime so they could
Well,
sleep.
there you go. And there's a testable hypothesis. Back to what we were talking about before. It's not resource neutral. Having to do a second med pass, is resource intensive, but it's an empiric question. You could try it out and see if diversion goes down. And then there's a cost benefit to that. It costs me nursing time, but does it save me all the resources and hassle of security control issues that diversion causes? I'm not predicting that it necessarily will solve it all, but if your hypothesis is right, that would be a plus.
As the economist says, you spend more, you get more.
Might be. And you could test it, right? You could try it for 6 months on a trial basis, count your diversion episodes and see if they go down. And if they don't, oh well, nice try. But I don't know if that's helpful, but it is be very interesting to test some of these things and to see. But those are some of the things we've heard. Another thing that we've heard is, I don't know if you were serious, but I think the St. Mary's folks have been dissolving buprenorphine as a liquid.
Oh, that's Wacomico.
Wacomico.
Wacomico, she had a compounder.
We do float it, there's,
Yeah.
but.
What does
we
floated
don't do-
mean?
We haven't tried, well, you put it in, water and, they bust it up and then take and put it in, give them water to wash it down. So when they get their dose, it's.
After they sit
crushed.
for a little bit. It's crushed, they put it under their tongue,
Right.
and then they have water, say, 10 minutes later.
But I hadn't heard of that, taking and let it dissolve totally and then.
She has a compound.
She has a compounding pharmacy
Yeah,
that makes it into a liquid, and you squirt a couple of drops under the tongue, and they have to sit with the liquid under the tongue. Again, swallowing it means it's not going to work. So you can't swallow it, and you can't take the water chaser too quickly, or else you lose the potency. But you can hold a liquid, not big volume, but you can hold a liquid under your tongue, and that's been a somewhat unconventional approach, but testable, reasonable, and as you said, the Wacomico people have really liked it.
Because I know, a lot of times the inmates want to see their medication before you give it to them.
Right.
I don't know how trusting they would be to dissolve it before you.
They might not, but if that were their only choice, for example, maybe not everybody, but the folks that are naughty. So now you've lost your ability to see the medicine first, and you're going to have to trust us for the next 6 weeks, 2 weeks, 5 weeks, 6 years. I don't know, but yeah. Again, you'd have to find a compounding pharmacy, but they exist everywhere. I don't know how expensive it is.
So I just want to ask a few questions in relation to working as an outpatient addiction provider, and wondering what your experience is with having patients bring back in wrappers. If that's something, because that's one of these things that some people apparently do in some places, and we haven't been doing it at our facility, but just a question of whether that works. And then the kind of follow-up question, I was just curious with the Sublocade in particular. There are many folks that we have that come in and say, oh yeah, I want to get off and be done. And we're trying, you kind of go through your week, you kind of do your induction, you're kind of getting ready, and then the question that week's over, like, well, now my buddy told me about this, and I'm not.
You mean they start to say, I want to get on Sublocade, but then they get cold feet?
So then they get cold feet, yeah. They get cold feet about a week later because, they're just not really so sure, and someone, so it kind of hurts, they didn't like it, or whatever kind of thing. And so I was just curious what you recommend for a conversation with them.
Okay.
Personally, because I have my own conversation, but I'm curious to hear what your conversation is.
So let's start with number 2 first, thinking about engaging folks. The first thing to start with is, well, what were the things that got them interested in the first place? And pushing those buttons again. I've been on Bupe before and didn't work so good, or I stopped it, or I used on top of it, or whatever the reason is, or it was inconvenient, or I hated having to come into the clinic every week, or I hated that they were always accusing me of not taking it, or whatever. Well, all those things go away, don't they, with this? So accentuate those things, come back to those things. Well, now my buddy said that. Well, what do you mean your buddy said? Get your buddy in here. Where does that come from? By the way, I find that if you get them to talk to enough people, most people have a very positive experience. There may be one person that they talk to who said it was terrible, but most people, I find, really like it. Another thing that I like to do for engagement, retention, and adherence is involve a family member or a treatment significant other or some closely trusted person who's willing to be part of things. Now, some people will not want to do that, and it's private, and it's none of their business, and I don't want my wife, my husband, my boyfriend, my girlfriend, my dad, my mom busting me. Well, but that's not the point. We're just trying to get you support. And if you can find a person who's willing to be part of that conversation, which, by the way, is pretty standard in the rest of healthcare, right? If Granny has trouble taking her pills or doesn't understand what the doctor is saying, or you take your kid in to the doctor and it's complicated for them to navigate, you go with them and you take notes and you get Granny a pill box or whatever. Count them out for her. That's right. You call her up and you say, did you take the blue one? No, I fed it to the plants, or I gave it to the dog. Well, don't do that. And anyway, it's standard, except in this field where it's shameful and in the shadows and secretive and we don't talk about it. And so, although it's a big lift, more of that. And it takes time, by the way. And we're busy enough in our clinics with 7.5-minute office visits. Who's got time to, get the loved one in? But telehealth helps, and that helps overcome barriers. Can we just call them up, or can we get them on Zoom, or that kind of stuff? So anyway, I advocate for that when you can get it going.
I have one significant other every time the withdrawal injection goes in, the dials the partner and
I love that.
latches it on, there it goes. And
I love that.
right there.
And let's get you out of the doghouse. They don't trust me anymore. Well, you can kind of understand why, but that doesn't have to last forever. Well, I'm clean now for 5 minutes. Why don't they trust me? Well, we need 6 minutes. So let's call them up, just like you say, and get you some points.
Yeah.
And be an advocate for them and cheerlead and get the family to cheerlead. Because most families are used to fussing and the misery and the lying and the cheating, helping them practice the rah-rah and the positive reinforcement, and you be a model for it and show the patient that they can get love for it instead of just curse. Yeah, it's good.
Yeah, I mean, my experience oftentimes the difficulty is that the patients that are trying to get on the Sublocade, the ones that have been on Suboxone a number of different times, they haven't come through. So now, okay, it's time for you really to look for to go the injection route. We're going to try something different, but then they're just not really willing to make that commitment.
Sometimes, and I'll tell you another thing. I've done.
At the time.
I'm not sure I'm proud of it, but I do it.
This is being recorded.
Which is, I say, listen, we've talked about this 6 different ways from Sunday, and we're going to just have to agree to disagree. And let's pretend one of us went to medical school, and if you want buprenorphine from me, it's coming in a needle.
We've done that.
Now,
our coordinator will call.
at the end of the day, I'm more bark than I am bite, and I might cave to get them buprenorphine instead of no buprenorphine.
Yeah.
But I talk a big talk.
Right, we've done that. We'll do the thing where our addiction coordinator will get a call from someone that I know has been through the round circle two, 3 times, and we're going to say, okay, we'll have you back. We have to agree to be willing to do Sublocade because we've got to try something different.
Try something different.
This time because it didn't work the other time. Or you can go, down to one of your around manner treatment centers and
Or go to a higher level of care.
Higher level of care.
Yeah.
If that's where if that's not going to work for you.
The problem is,
Then still, when they get in there, it's that stringing along trying to get.
Yeah,
What they
yeah. No,
get,
it's hard, it's hard. And the problem is, as you well know, there's always somebody down the street that's gonna give them a month's worth of buprenorphine and 6 refills and 6 milligrams a day of Xanax and some Adderall and a bottle of Jack Daniels all in one prescription. And they can shop elsewhere, and sometimes you have to say, well, then I guess you're just gonna have to shop elsewhere. I hate to say that, but, and I don't say it often, but I have said it. Again, not on camera.
Okay. Any thoughts on the kind of wrappers?
Sure. So the issue of trying to address or prevent or monitor diversion through pill counting or bottle checks and recounts or wrapper checks and recounts has variable success. I don't think I've seen any data about it, but it's a relatively common practice, and it might be routine for a particular clinic. Everybody gets one of these procedures. It might be for cause, somebody who's suspected of diversion. Let's do extra monitoring in a graduated or stepwise kind of way. And that can include randomly or even in a scheduled way, mid-month, I want you to bring back your bottle of pills, and I want to count them. How come it's 15 days in and I gave you 30-day supply and there's none left? Let's have a conversation about that. Or it could be bring in the wrappers from the strips. Or it could be random recalls, any of those things. And I tend to think the juice is not worth the squeeze to do it for everyone. But I would do it sometimes for cause when you're really concerned about someone. The other thing that you probably do, and most people do, is have the availability to check for buprenorphine in the urine, and even better, to check for its biological breakdown product, norbuprenorphine, because some people will sprinkle a piece of a crushed pill in the pee, and then that will show up as buprenorphine, but it won't show up as norbuprenorphine. Now, of course, there is no monitoring that is perfect, and where there is a will for fooling us, there is a way. You know, we're never going to be ahead of the person who really, really, really wants to fool us. So I've certainly had patients who take their buprenorphine when they know it's urine time and sell the rest. You can do that. And I've had patients who buy buprenorphine positive urine because that's available on the market. They're very indignant when that urine happens to have cocaine in it. I paid good money for this pee and it was supposed to be clean. Well, consider your sources. I don't know what to tell you. Maybe it's a side business for the clinic. I don't know, but anyway.
Yeah, well, let's kind of give you the scenario a little bit. So I have a mother with two kind of, 28-ish year old kids. So both kids have pretty good responsible jobs in my private practice. But it seems that, we've had experience with them, that every so often, because it's kind of a triumvirate there, that for a while one will come in, and then another one will come in for a while, and then they'll come back.
And all three of them are in treatment.
And all three of them are in treatment,
Yeah.
and they clearly aren't getting their scripts on a regular.
But there's enough to go around.
There's probably enough to go around
Yeah.
with it, and I just haven't solved this problem. I guess that's so. I don't know if you know. So my latest thought was, well, is it worthwhile to try to come in and try to do the?
You could try, and sometimes it's just enough that you've made a fuss, and they hear you saying, listen, I'm concerned about this, I'm concerned enough to do some procedure, I'm worried about you, this is not okay. Sometimes you can just get that from a conversation, but sometimes you need to go further and rattle your saber a little bit. I wouldn't throw somebody out over it, but I've had, here's an even worse conundrum. I've had patients who say, well, I am just selling 2/3 of it. And then I think the right thing to do is to cut the dose by 2/3, but then they yell at me about that. No, I was just kidding. You know, it is very difficult. And the same thing, by the way, not just to buprenorphine, pertains to all sorts of medicines, right? Our chaotic families are swapping every which thing. I felt a little down, so I took my cousin's Prozac last night. Or I was anxious, so I took my aunt's Xanax last night. I mean, we see that stuff all the time.
What is the meta wheel? Mike Shazia in one of his studies, right, where it dispenses a dose every day. It's a locked box.
So
can you talk about that?
Sure.
Because that's obviously, that is the whole point, is minimizing diversion of medications like that.
So there are a bunch of interesting ideas out there that are worth talking about. They're not ready for prime time and commercially broadly disseminated, but people are constantly trying to come up with interesting extra gizmos. So one idea is obviously the long-acting injectables we've been talking about. Another idea is even longer acting implants. So we will eventually have long-acting implants of naltrexone, which have duration of 6+ months. Those are in the pipeline. And people are trying to do the same thing with buprenorphine. And you may know that there was a product called probufene that was implantable rods in the forearm that had 6-month duration. Not sustainable in the market, too low a dose. The implantation was easy, but the taking it out wasn't so easy, so it was a bit of a dud in the market. But somebody will come up with something like that again, and people are even working on long-acting methadone. That's probably further off in the pipeline, and some of you, well, you're not as old as I am, but you may remember LAM, which was a version of a long-acting full agonist like methadone that was administered 2 or 3 times a week, then was taken off the market for safety concerns. And some people say that we may have been too trigger happy about that, and the side effects weren't that bad anyway, let's reintroduce it. I don't know if that'll happen. But anyway, so that's one set of ideas. Another set of ideas, is, as Dr. Mitchell mentions, are gizmos that can help with monitoring. So you may have seen newspaper or research accounts of video monitoring, where people take their medicine, say their sublingual buprenorphine, in front of a camera or in front of a gizmo that has a camera with an automatic upload, or maybe it's just that they text their camera's video clip to a particular place, and there's a central station where either computers or people are monitoring videos and watching people take the medicine. Now, it's not that you can't, what's that?
Sober track, so people engage how much alcohol is.
Yes, for example. It's a similar idea. Now, it's not that you couldn't stage taking the medicine, you know, with the right lighting and the right special effects, and you could go to the trouble to send in a false video, but it's work. At some point, it's just less work to do the right thing, right? So that's one idea. Another idea is a dispensing machine. So we've done some work, and Dr. Gordon has done some work with an outfit out of Massachusetts that's got what is essentially a Pez dispenser for buprenorphine. So it's got a cartridge with whatever supply you decide to prescribe, a week's worth, 30 days worth, with the proper dose. Right now, they've done it only for tablets, because they haven't quite figured out the engineering of how to get that thin paper strip dispensed, but they'll figure it out. And it's got remote internet radio control to be able to monitor dispensing 1 time a day, 2 times a day, whatever is prescribed, dose adjustment from afar, if that's what the doctor wants to do, and recording of the monthly medicine taking. Could a person fool it? For sure. Could a person break it open with a sledgehammer? For sure. But again, it's a lot of work.
It is.
And so it's at least something of a barrier. Our early work with the company is that the tech is still wonky, but it'll get there, right? The engineers and their stockholders have enough incentive. They'll eventually figure it out. So lots of interesting ideas. Another idea which we don't yet know how to finance, is contingency management as a strategy for rewarding people for good behavior. The traditional and most well-studied contingency management strategy is giving people incentives or rewards for producing negative urines. But you could link those motivational incentives to a different target behavior, like medication taking. Take your medicine right, and you get a bonus. Now, I don't know who's going to pay for that, but it's at least an idea that has some evidence behind it, and if you could figure out the practical logistics, it might be worth it.
Or what would be the hook for people?
Or it might be the hook for people. I just want to say one last thing, because I just want to emphasize here, we spent a lot of time talking about this and this, but I just want to remind people that as good as these medicines are, and as good as we get in terms of initiating people on treatment and overcoming barriers and working on adherence over time and finding the right dose, as good as these medicines are, in the best research studies with the most intensive case management and extra resources and calling people every day, 6-month retention is what?
50%.
You're not allowed. Of course, you're a researcher. Yeah, it's 50%. That's the best we can do, even with all the NIDA money in the world. And in everybody's real world settings, it's much worse than that. So part of the problem is we need to think about how to get people to do this more for longer. And having all the jail programs in the world start people and having all the doctors in the world ready to treat people doesn't necessarily address this fundamental problem that people get tired of treatment and they drop out.
I get it. Weight Watchers.
Well, there's also a prevention part at the very.
Ah, nice, nice. So that's right, you can't fix any epidemic just with treatment. We got to reduce the pipeline in. And what's the #1 strategy for that? There's many, and many of them are good, but give me #1. What's the thing that's going to have the biggest impact, and we ain't doing it? And we're not doing it. We've already done a lot with supply of opioid pain medicines, right? We made a big piece of progress there. In fact, we've swung the other way. Now you can't get pain medicine to save your life even when you need it, right? So that's America, right? We only do things in extremes. But what's the thing we're not doing that we ought to do? Who starts opioids? Who is it that is vulnerable to initiation? Our teens, our young people. Most people who initiate opioids lose control of opioids, escalate their opioid use, and develop use disorder are people who have already lost control, had impairment, and had use disorders with other pre-opioid substances in their teen years. 90% of people who have an SUD later in life began before the age of 18. And what did they begin with? Alcohol, cannabis, and nicotine. And what are we doing about that? Not too dang much. But that's...
Legalizing marijuana.
Ah, what a great idea! Anyway.
Thank you so
You're
much.
welcome.
Yeah.
Good.